right, thank you. Good afternoon, everybody. And thank you for the Emirates Cardiac Society for inviting me to participate and talk about unique cardiovascular risk factors in women. So as I mentioned earlier, we'll start by looking at mortality. You know, the reason why we're all here is that cardiovascular disease remains the leading cause of death in both men and women. And this curve illustrates mortality in men in blue, women in red in the US between 1980 till 2011. And as I mentioned earlier, you can appreciate that starting in the 1980s, there was a significant drop in cardiovascular mortality that only men benefited from. During that same period, cardiovascular mortality actually increased in women, and it took really 30 years to close the gap. What we don't see here is that over the past 10 years, unfortunately, cardiovascular mortality has plateaued, and since 2017, it has started to increase in women, particularly certain subgroups of women, so certain ethnicities and young and middle-aged women. So we still have a lot of work to do. And as Dr. Mirvat mentioned earlier, cardiovascular disease can impact women at various degrees, at various stages of their life. So this is not a post-menopausal entity, but we have to be aware that our women, even in their reproductive years, are at risk. So how do we assess our patients' risk over a lifetime? So we start with the traditional risk factors. Actually, 80% of women by the age of 40 have at least one risk factor, one traditional risk factor. So 80% of women by the age of 40 are already at risk of heart disease. And although men and women share the same traditional risk factors, the potency of these risk factors is different. For example, diabetes confers a higher risk in women than in men. If you look at this meta-analysis of 64 cohorts, you can appreciate that the relative risk of coronary artery disease associated with diabetes in women is much higher. It's 2.8 compared to 2.2 in men. So women with diabetes have a 44% greater risk of heart disease compared to men. And if you break it down, you can see that when a woman is diabetic, that triples her risk of dying from heart disease, whereas in men, diabetes will double their risk. Similarly, tobacco use has a stronger impact on women than men, particularly young women. So as this graph illustrates, women that are younger than the age of 55 who smoke, their relative risk increases by 7 times, whereas in men, it's tripled. So when you are with a woman smoker, especially if she's young, the most important thing you can do for her before she leaves is to really convince her and help her in quitting tobacco use. Hypertension is obviously not unique to women, but it strongly impacts women. And this is also an article by Dr. Wenger that Dr. Mirvat also mentioned that shows that after the age of 60, women own hypertension. So 2 out of 3 women are hypertensive after the age of 60, and the prevalence is higher than in men. And if we look at deaths that are attributable to individual risk factors, in women, high blood pressure is the leading cause. And despite that, when we look at recent data, nearly 50% of women are undertreated when it comes to hypertension. But we have other opportunities to assess and treat cardiovascular disease in our patients, so we don't want to wait till they're post-menopausal. Even young women, it's important to ask them at what age they started their period, for example. We now know that if they started very early, younger than 10, or the other extreme, later than 17, this is associated with an increased cardiovascular risk. Polycystic ovary syndrome is prevalent in up to 8% of women, and it's a heterogeneous syndrome, but at its base, it's defined by the presence of polycystic ovaries, irregular menses, and hyperandrogenism. And a lot of those patients have associated metabolic syndrome. They have elevated triglycerides, hypertension, obesity, and all of that obviously puts them at risk of developing cardiovascular disease. The average age for menopause is 52, But when a woman has experiences early menopause, defined as menopause before the age of 45, that is associated with a higher risk of cardiac disease because of the early and abrupt loss of the cardioprotective effects of estrogen. And the earlier the menopause occurs, the higher the risk. So for example, in women who either naturally or surgically undergo menopause below the age of 40, that increases their risk by 36%, even when we adjust for other risk factors. And as was mentioned earlier, autoimmune disorders are not specific to women, but they're much more prevalent in women, and especially lupus. Lupus affects young women. So when they have lupus and early inflammation very early on, they're exposed to this longer duration of inflammation. And because of that, you could see that it increases cardiovascular mortality 50-fold. So women with lupus, are at they die from heart disease. So it is important to recognize that in your patients. But I really want to talk about pregnancy because this is a unique opportunity we have in women who decide to have a pregnancy. Pregnancy is not only nature's stress test. We think of it as nature's stress test because there's an increase in heart rate, there's an increase in volume status, but there's more than that. Pregnancy is also a vascular entity. We're dealing with a placenta, so it can give you a window in a woman's future cardiovascular health. You can actually see how your patient is going to deal with vascular issues and extra volume. And it's not uncommon. Adverse pregnancy outcomes currently complicate 10 to 20% of pregnancy, but this is on the rise, mainly because of the obesity pandemic and because women are choosing to start families later in life. So any of these adverse pregnancy outcomes, whether it's hypertensive disorders of pregnancy, gestational diabetes, intrauterine growth restrictions, so babies that are smaller than the 10th percentile, have all been linked with long-term cardiovascular risk, and the risk is higher the more severe the case or the more recurrent these APOs. So if we look at gestational diabetes, it occurs in 1 in 10 patients, and even though most of these patients might recover like normal glycemia after their pregnancy, in 5 years, most of them will become diabetic. And this was a study that was done in France. They looked at 7 years outcome, and they found even when they adjusted for age, diabetes, obesity, and all the other risk factors, the fact that these patients had gestational diabetes did increase the risk of cardiovascular disease by 25%. And this is echoed here. This is a meta-analysis of 9 studies with a large number of women. And again, they showed that gestational diabetes doubled the risk of heart disease in women, particularly in the first decade. And even if they adjusted, or even if they looked at women who did not go on to develop diabetes mellitus, the risk was still there. Not as strong, but it is still there. Hypertensive disorders of pregnancy are the most common cardiovascular complication that we encounter, and the cutoff for the diagnosis requires 2 separate measurements of blood pressure above 140/90. And just to let you know, normally pregnant women have a drop in their blood pressure during the 2nd trimester, and in non-pregnant women, we're considering a cutoff of 130, right, for systolic hypertension. So when a woman who's pregnant has a blood pressure of 140/90, this is grossly abnormal. When we're going to talk about hypertensive disorders of pregnancy, there's several. But the 2 that we're going to focus on most are gestational hypertension. So these are women who were normotensive before and developed hypertension after the 20th week of pregnancy, and preeclampsia, which is similar. These are women who have hypertension after the 20th week, but with proteinuria or signs of end organ damage. This group in Mass General looked at the UK Biobank data and identified women with a history of hypertensive disorders of pregnancy. So they basically self-reported that they had a history of HDP. And here the prevalence was actually pretty low, 1.3%. And when they compared them to women who don't have a history of HDP, there was a significantly higher prevalence of hypertension in the woman with a history of hypertensive disorders of pregnancy, which not only occurs early on. So if you look closely here, you'll see that young women in their 40s or 50s when they were initially enrolled, so they probably had their pregnancy in the past 10 years, there was a big difference between the prevalence of hypertension between the two groups. But this difference continued even later in life. So even at the age of 65, women with a history of HDP were much more likely to develop hypertension. And more importantly, they were much more likely to develop coronary artery disease, heart failure, and even aortic stenosis and mitral regurgitation. This is an interesting study that was just published last year from the Brigham and Women's. So they looked at women that were enrolled in the Nurses' Health Study. They identified 60,000 women who had completed the questionnaire in 2009, and 12% of those women had a history of hypertensive disorder of pregnancy. And what they noticed is when compared to the women who didn't, you could see that a history of HDP conferred a higher risk of coronary cardiovascular disease in this woman, particularly if they had preeclampsia in comparison to gestational hypertension. The other interesting thing in this study was they looked at the difference between coronary artery disease and stroke and preeclampsia and gestational hypertension. And what they noted is if a woman had a history of preeclampsia, she was much more likely to have coronary artery disease, but there was no statistically significant difference in terms of stroke. The opposite is true as well. So women who had a gestational hypertension were more likely to develop to develop stroke, but not coronary artery disease, which tells us that even though we group these two disorders together, their pathogenesis might be a little different, meaning that gestational hypertension is a hypertension prototype. It is ultimately hypertension that these women would later suffer from. And they calculated that by proportion mediated by risk factors. So basically, when we see women with a history of adverse pregnancy outcome, and we know that they're at a higher risk of cardiovascular disease later in life, are they at a higher risk because they go on to develop hypertension or because they have other cardiac risk factors? Or is it the adverse pregnancy outcome in itself that triggers something and results in an increase in cardiovascular outcome? So it looks, based on their data, that in women with gestational hypertension, most of this risk is mediated through hypertension. So 83% can be explained by the risk factors, but it's much smaller when you look at preeclampsia. So like over 40% of that risk cannot be explained by risk factors in preeclampsia. So preeclampsia seems to be different, like a somewhat different entity. As I mentioned earlier, it's the definition of preeclampsia is hypertension after the 20th week of gestation with evidence of end organ damage, whether it's proteinuria, impaired liver enzymes, thrombocytopenia, etc. And it is a very significant disease, right? It's not a benign disease. It contributes to 7% of maternal deaths in the U.S., and it is associated with morbidity and mortality in both the mother and the fetus. And there is no treatment for preeclampsia. As you know, the only treatment is delivery. So the risk factors for preeclampsia are very similar to cardiovascular risk factors. It's age, diabetes, hypertension, autoimmune diseases. So these women actually benefit from being on aspirin early on. Aspirin has been shown to help prevent preeclampsia if it started early in the first trimester. So even though preeclampsia presents clinically late, it starts very early on. It starts with the placental implantation. So this is the shared pathogenesis of adverse pregnancy outcomes, but it's particularly important for preeclampsia. So you can appreciate that in normal pregnancies, there's a lower vascular resistance in women. However, in women who have adverse pregnancy outcomes in preeclampsia, because of this inadequate placental implantation, they have increased vascular resistance, they have increased inflammation, and there's evidence of anti-angiogenic proteins that is detected in the woman's blood. So to sum it up, basically, the truth is probably in between, right? So these women have risk factors for cardiovascular disease at baseline, but not all of them. Like we've all seen young, thin, healthy women who might develop preeclampsia, right? And probably these women are even at a higher risk of cardiovascular disease than their counterparts that have risk factors. But a lot of these women do have risk factors for cardiovascular disease, and then you add to that an abnormal vascular placental implantation. This can trigger adverse pregnancy outcomes, and this leads to changes that will continue even after delivery and ultimately lead to the cardiovascular disease that we see even long-term, even 10 years, 25 years later. This is a study that was done in Denmark that showed that women with preeclampsia were also more likely to have evidence of coronary artery calcium on cardiac CT and even any type of atherosclerosis, even when they adjusted for cardiovascular risk factors. So it is important to ask about pregnancy when it comes to our patients, and the other thing that is really important to ask about the lack of pregnancy. So if a woman has recurrent miscarriages, especially if it's later in pregnancy, so not in the first trimester. So in the first trimester, most of those spontaneous losses are due to chromosomal abnormalities, but after that, it could be related, or most likely related to the mother, right, to the vasculature, to the placental implantation. So again, this is a study looking at data from the Nurses' Health study that showed that women who had recurrent spontaneous pregnancy losses, but even one, were at a higher risk of developing cardiovascular disease later in life. So what do we do with this information? I think the key thing is to educate your patient. I'm surprised by how many patients we get with a history of APOs who, after their delivery, their blood pressure normalized, their blood sugar normalized, and they think they're done with this. They don't realize that their risk continues. So it is important that the patient knows that she's at a higher cardiovascular risk, and that those patients get directed to cardiovascular clinics that specialize in, whether it's cardiometabolic clinics or women clinic, where they will get a full cardiovascular assessment at 3 months or at 6 months. What can we offer them? So there is no specific therapy, but we can ensure that they, pursue healthy lifestyle. Exercise has been shown to help prevent preeclampsia in certain instances. And in one Danish study, breastfeeding, even for 4 months, was shown to reduce hypertension and cardiovascular disease, even at 7 years. So based on all the evidence I presented, the American College of Cardiology has incorporated adverse pregnancy outcomes and early menopause as part of their risk enhancers. And this is useful for your patients that are borderline or intermediate risk, so we tailor our management now, or how aggressive we are in treating patients to their risk. So if we correctly identify that these patients are higher risk, then we're more likely to aggressively treat them. One more point. So again, if we just focus on traditional risk factors, we'll be missing a big piece of the puzzle when it comes to assessing cardiovascular risk in women. So I've spoken a little bit about adverse pregnancy outcomes, autoimmune disorders, but there are other things that we can look at. And the other important thing that is not necessarily unique in women, but more prevalent in women, is depression, stress, and anxiety. That also factors into cardiovascular disease. And to sum it all up, I'd like you to go home with these take-home messages. One, that although women and men do share traditional risk factors, the impact of these risk factors is different in women than men. So women with diabetes and smoking are definitely at a higher cardiovascular risk. And pregnancy really provides us a window of opportunity to learn more about our patients' cardiovascular health. So it is important to ask them about how many pregnancies they've had, preeclampsia particularly, or any adverse pregnancy outcome. And these have been incorporated in European and American guidelines. And any woman with a history of APO should be identified as higher risk and should undergo closer cardiac follow-up, should undergo a more aggressive lifestyle modification and pharmacotherapy, whether it's statins or aspirin as needed. And with that, I'll stop there. Thank you.